So, last but by no means least, welcome to the stage Dr Simon Wright, who's going to deliver the final abstract presentation.
Thanks very much, everyone. Afternoon now. Thank you very much for the introduction, Jude. Crikey, I wasn't aware that my presentation would actually have my face on it, and that's instantly unsettled me, along with the timer and following three wonderful presentations, but I will do my best to entertain you for the next 10 minutes or so. My name's Simon Wright, as you can see. I'm a GP and I come to you from Dorset on the south coast, and I have been fortunate enough to be working with NHS Dorset for the last 22 months on the deployment of pseudoscience in general practice across the whole of NHS Dorset, and I wanted to present to you a bit of quality improvement work we did in our practice, which hopefully will lead to a recommendation for improvement for the whole of pseudoscience. And I could see Jude's face kind of crinkling up at the thought of it, because I do kind of cram up your inbox with recommendations for improvement, but I promise this one's a good one. So we aren't the largest practice. We're a practice of 8,000 patients, and what I'm about to present to you is a bit of quality improvement work that comes in the form of a retrospective audit. As with most quality improvement projects, it began with a significant event. The case in question here was several years ago with a patient at the practice who presented multiple medical problems at the same time, but one of the issues was for a review of his marginally raised PSA test. He was requested in that consultation to book for a repeat test. For whatever reason, it didn't happen. Presents 18 months later with metastatic and incurable disease. At that time, we had no mechanism for safety netting those second PSAs whatsoever. So, in and around the same sort of time that Dorset deployed pseudoscience, which was first deployed on the 9th of August 23, we developed a new SOP to introduce and integrate PSA safety netting into our dashboard, not in a dissimilar way to what Bush was demonstrating with fit testing, but we tried to take it a step further with regards to second PSA safety netting. So if you look at this slide, there's three captions here from the fast-track urgent suspected cancer safety netting form from Dorset, and you can, if you digest that for a minute, you can see the quandary that GPs have put in there, because you can refer a patient directly to urology with a single raised PSA test, but you can also see the other information that's been added underneath that at the request of our local urological department that says, well, actually, you can consider repeating that test in 6 weeks' time if there's no obvious reason for the PSA test to be raised. We'd all like to practice patient-centered decision-making, so our new SOP in our practice is to pick up the phone to a patient when they have a raised PSA and discuss with them what they would like to do. So this forms the touchstone point of our new SOP. We discuss the raised result with the patient and decide whether or not they would like an initial referral directly to urology, or they would like a repeat PSA test in 6 weeks' time, which anecdotally is what the majority of the patients that I speak to seem to wish to do. Similar to the way that Bush was describing fit test chasing, we chase those every month. Non-responders are contacted with increasing levels of aggression until they respond. The normal second, if the repeat PSA is normal, they are then offered annual surveillance with repeat PSA testing, which then we log into our recall system. But abnormal second tests are obviously referred. If you take nothing from my presentation, take this, because this was good. We achieved 100% safety netting on all second PSAs for new prostate cancer diagnosis in the test period, which covered 22 months since the inception of pseudoscience. So I'm not going to bore you with the methods, because it involved me spending a long time alone in my study looking back through System 1 audits and searches. But effectively, what did I want to know from doing this work? I wanted to know, first of all, how many PSAs are we actually doing in the practice? Are we providing enough of a service? Secondly, how many cancers were found within the test period? I wanted to know the impact of safety netting from the pseudoscience perspective on the dashboard and any other findings, because there were other findings. It's quite interesting. Sorry, my slides are really naff. I put them together like at the last minute. There should be some colours and stuff on here. Anyway, you're going to have to listen to me to get the interesting data. So we did 762 PSA tests within that 22-month period. I thought it was interesting to observe that about 45% of them were in the last 6 months, so it really shows that kind of uptick and increased population awareness of the test. We're seeing so many more requests for PSA testing. The curve is really taking off, which kind of underlines the importance of having a proper safety netting system. 155 of the 762 were abnormal. So the next slide breaks down the results a little bit into where those results came from. The first group, Group A, I've called PSA surveillance monitoring. So these are patients who've got things like benign prostatic hypertrophy, or they've already got prostate cancer, and we would expect a PSA to be abnormal in those cases. So somewhat to be disregarded, and you'll see I've taken those out in the slides to come. But the following groups, B, C, and D, are the ones where we've got an abnormal PSA. Group B is where the abnormal first PSA, and they're going straight to referral. Group C is abnormal first test repeated, and the second test is abnormal, so they get fast-tracked. And Group D is the abnormal first test repeated, and then the second test is normal, so they return to standard follow-up. So you'll see Group C and D are the actual dashboard safety netting patients. So those are the people that are really important that we make sure they safety net to avoid cases like the SEA I said at the top of the presentation. So this confusing slide doesn't look much at first glance, but you'll see, I want you to draw your attention to, if you take away Group A, which is this PSA surveillance monitoring, and look at C and D, those are the dashboard cases. So that's looking at 58% of patients that went on to had a PSA was safety netted on our dashboard. Group B was the group that went straight to test. So as I said, you take out that surveillance group, and you can see here that we had 67 patients who were referred. That's the combination of the top right group and the bottom right group, which resulted in 20 new cancer diagnoses across the 22 months that See the Signs was deployed. 90 patients were safety netted though on the dashboard, so that's a combination of the bottom right and the group on the left-hand side. And we're taking it as proof that the system works because we've had no new SEAs in that period of time. We've had no more patients who've missed that diagnosis. But I thought this was really interesting data, and being quite nerdy and OCD about the whole thing, I wanted to look a little bit more into the data, and I wanted to see where those 16 cases of cancer came from, appreciating that there's small population values and potentially lower statistical power. So of the 20 patients that were diagnosed with prostate cancer, 16 of them came from the repeat PSA group, whereas the only 4 came from the immediate referral. So I think this really underlines the value of kind of watchful waiting in primary care, and potentially that you can infer from that data as well that the group on the left-hand side, the 49 patients who had the second normal test, those patients have avoided unnecessary investigation and potentially unnecessary harm to them. The study began with an investigation into the dashboard effectiveness, and I can really happily say that we had 100% successful safety netting on the See the Signs dashboard for these second PSAs. So, my conclusions. Number 1, PSA testing is definitely increasing, and that's a good thing. Dashboard safety netting, I think, arguably increases the safety for patients. Repeat testing may reduce the need for unnecessary investigations because of that potential higher positive predictive value in having 2 abnormal PSA results rather than just the 1. And repeat testing itself, as I've said, may increase the positive predictive value. Now, my plea for this would be that as we've got the fit test section for safety netting on See the Signs, I would love for there to be a section next to it for second PSA safety netting that could then automatically roll into the dashboard, and then we could follow this through, because the mechanism for putting PSA patients on the second PSAs on the dashboard isn't as slick as the fit tests. But I'll leave that plea with you guys. And that QR code links to my LinkedIn profile such that it is. Thank you, everyone.
Great, thank you, Simon. Any questions from the room? Got 2 over here.
Hello, I'm also from Dorset. I'm from Poole.
Hi.
Set up at 6 in the morning and still was a little bit late. My question is about when you check PSA tests, do you go in the notes and check if patients are on finasteride? We just recently had a complaint. Test was normal, but patient was on finasteride. So if it was doubled, it would be slightly abnormal. Then he went for investigations and was found to have cancer. Well, he's treated, all fine, but still, do you feel that it's needed to add when checking PSA tests, and because they're increasing and it increases the amount of work for GPs?
I think it's a wonderful question, and the honest answer to your question is that ought to be taken into account, isn't it, every time you interpret a PSA test? But I do wonder whether or not it is something that's within the scope of See the Signs, certainly with case finding, to note, because if we're essentially looking at case finding as Miles presented earlier, and we're trying to pick up patients who've got a raised PSA that hasn't potentially been actioned on, it's not outside the bounds of possibilities that you could incorporate whether or not the patient is taking any medication that could artificially lower their PSA into that decision making, I think. So no, not on my part, but fingers crossed for the future. So I'll try and answer your questions before Jude kicks me off the stage. Like she did.
Hi.
Yeah.
Hi, I was just wondering, for the group that you were then doing after a second normal PSA, you were then choosing a year to then follow up their PSA. Have you got a timeline that you then have a plan to do that on an annual basis for how many years, how many normal tests? Because I wasn't aware in guidance that it said for if you'd had a normal PSA to then routinely follow it up annually, but maybe I've also missed something. And the second part of that is if people have chosen to have one raised PSA test, gone for investigation, do you then put them onto your annual follow-up PSA if they've been seen in the hospital and they've said nothing is on, because they've, by the logic, still had one abnormal PSA test, but then wouldn't necessarily be on an annual follow-up? So it's around those bits, please.
This is probably the problem of doing this sort of presentation in front of a room full of very, very intelligent people, because I don't have an excellent answer to either of those questions. We kind of made it up, is the honest answer, because we felt like annual surveillance is usually what the urologists say that you need to do when you write to them with a borderline PSA that then comes back to normal. So we kind of tried to that's what we did in terms of putting it into our surveillance process. It's not easy to safety net those patients, though, through the See the Signs dashboard for 1 year. So we build that into our normal recall processes within System 1 is the prevalent area where prevalent system where we work. Does that cover your first question? Not really your second bit, though. Yes. It depends what the urologists say, I think, usually, yeah. And then it's just from observation of being a working GP now for longer than I want to share with everybody in this room. But it seems you get a huge variety of responses back from the urologists about how often they recommend PSA testing. They use this kind of magic thing called PSA density, don't they? I don't really understand what that is. It sounds like some sort of density measure for a fruitcake or something like that, but it does seem that they do this kind of finger in the wind thing where they say that repeat it every 3 years, 5 years, or 1 year. So yes, I would just do what the urologist says, like a good GP.
Great, probably got time for one final question, if anyone's got microphone. Okay, thank you very much, Simon. So. To finish off, can we just do one extra round of applause for all 4 of those excellent presentations? So we're going to break for lunch now. There's an hour for lunch, so please, we're going to start again at 1:35 for our next keynote speaker with Paul Baker. So please do join us for that. And feel free to, I'm going to recommend this for the colleagues on my side for them, but grab them at lunchtime if you've got further questions, ask any questions, and also have a look at the posters. So as we mentioned at the beginning, there's going to be some voting later on. So if you haven't already had an opportunity, have a look at all of those. Thank you very much.